Hey guys, so today we're going to be talking about pathological gait patterns, and you're definitely going to want to have not only using Physio U, but your score builders as well as your Kisner and Coleman textbook. There's some information in your O'Sullivan, so there's a lot of resources for gait to use. I'm not going to spend time on reviewing normal gait, but make sure you review that from 150 and also in your score builders about how the different standard versus Rancho Los Amigos terminology, as well as the muscles and the phases and all the different phases. So make for sure you review that information. And, when we talk about clinical observation, it's good to make for sure you observe gait training through the front and or behind, to observe for the different pelvis and trunk position, looking to see about the hip, if it's abducted more so or adducted more so. The knee, if it's more varus and valgus, is going to show you more from the side view. And the calcaneus and heel and varus and valgus, it's good to go from the front, the side, and the back. But in the front and the back, you're going to see that more so when it comes to the heel. Looking through, for when you're observing from the front or the behind, you're going to see these different trunk rotation, pelvis rotation, hip rotation, the knee, the foot rotation, and how it progresses. When you're from the side, you're going to be able to see more of the flexion extension of either the arms and the trunk, like a trunk tilt, like a pelvic tilt, as well as is there any flexion extension coming from the knees, the hips, or the hip and the knees and the ankle, and if there's a reciprocal arm movement and leg. So footwear. So if possible, watch patients with normal footwear and bare feet and compare between the two. Also looking at their shoes to see where any wearing down of the heels or from their socks, and looks for creases in shoes. Some other things you could observe their feet and see about blisters, bunions, neuropathy, callus formations. So one of the biggest things I really want you to look at are these common gait deficits. So antalgic gait, and it's, I do have some videos, but I don't think this one I do. But on Physio U, there's some different videos that you can look at to show what might an antalgic gait pattern look like. And that just means to be painful gait pattern, and it's a protective gait pattern. So where they're during the stance phase, there's decreased weight bearing happening on that affected limb, and they avoid weight bearing on that involved side because of pain. You'll see more of a rapid and shorter swing phase of the uninvolved limb. Causes of antalgic gait could be because of disease, usually bone or joint inflammation, or injuries to muscles, tendons, and or ligaments. So it just depends on what's being painful. I do have, I think, a link on here too that you can look on this PowerPoint slide. An ataxic gait. This is just a gait pattern characterized by staggering or unsteadiness. And usually they'll have like a wide base of support and movements are exaggerated. So ataxic gait might look a little bit different from one person to the other depending on their balance, but it tends to have poor balance and wide base of support. They could have, if they have cerebellar ataxia, it's going to have more stagger, lurch or stagger, and all movements are exaggerated. They'll have lack of muscle coordination, poor sensation. So, patients will usually watch their feet when they're ambulating, and the gait is just irregular or jerky, or they're weaving. They could be a possible high fall risk and need to guard and protect patients and protect your patient accordingly. Here's another link that you can watch for ataxic gait. Equinus gait, I'm trying to see, or equine gait. So his gait pattern characterized by high steps, usually involves excessive activity of the gastrocnemius. And so go on, make sure you look over that video as well, what that looks like. Glute maximus gait, which it's not mentioned, it looks like in your score builders, but it is in your textbook. And going back to a lot of these pictures I took from 150's textbook, so you can look through that information as well. But this is when they have weakness of the glute max, primarily the hip extensors, and they thrust their thorax posteriorly to maintain hip extension and stance face through the leg. So they're leaning over a weak muscle to maintain that balance and function. There's also a video on that one too. A glute medius gait. of Trendelenburg gait, where there's hip drop on either of both sides, and weakness of the hip abductors, like the glute medius and minimus. They're unable to use these muscles to stabilize during the stance phase. A lot of times the thorax is thrust laterally to keep a center of gravity over the stance leg, and the contralateral leg or contralateral side will drop, so we can look over that one too. Hemiplegic or hemiparetic. Now for this one, I'm trying to think if there was mentioned, yeah, hemiplegic gait pattern in which the patient abducts the paralyzed limb. They swing it around, bring it forward so the foot comes to the ground in front of them. And so a lot of times you'll definitely see that with a stroke patient for sure. And so you can review that video too. The waddling gait, for this one, they have, they could have weakness in many muscles like dystrophies. You might see the shoulder behind the hips, increased lumbar lordosis, pelvic instability, and Trendelenburg gait. They'll have little to no reciprocal pelvis and trunk rotation, and the entire body must swing forward to advance the leg forward. And often the steppage gait is also present. And I think I have maybe a video online for that. If not, you can look that up too. Parkinsonian gait. This is where, obviously a gait pattern this will be marked by increased forward flexion of the trunk and knees, and gait is shuffling with quick small steps, and festinating can occur with that too. Festinating is just a gait pattern where a patient walks on toes as though they're being pushed forward. It starts out slowly, and then that will increases and may continue until the patient grasps an object in order to stop festinating. So you can look over that one and the video of what that looks like and being able to identify it. The psoatic limp, I'm trying to think that I don't see that in the score builders, but this is like similar like with Legg-Perthes disease, difficulty in the swing through where it affects the hips. They might have exaggerated trunk and pelvic movement and may be caused by weakness or inhibition of the psoas major muscle. And they usually have external rotation, flexion, and adduction of the hip. And here's a video of what that Legg-Perthes disease would look like. For short leg gait or leg length, and one leg is shorter than the other, a deformity of bones, they'll have a lateral shift onto the affected side that look, not very uniform. It might look a little more clumpy, so to speak. Steppage or drop foot gait. This results because of a paralyzed or weak or paralyzed dorsiflexors, and results in foot drop or drop foot. And they'll compensate to avoid dragging the toes, so they'll have a steppage at high elevation to clear the foot from dragging on the floor. And a lot of times they'll have increased hip flexion to lift the knee higher to clear the toes. The other thing too, the foot will slap at initial contact with the ground, secondary to the decreased control. So scissor gait, this is a gait pattern in which the legs cross the midline and with ambulation upon advancement, and results of spastic paralysis of the hip adductor muscle. The knees are more drawn together and often referred to as a spastic gait because they cross midline too. Vaulting is a gait pattern where the swinging leg advances by compensating through the combination elevation of the pelvis and plantar flexion of the stance leg. And so that way it can advance forward. And here's some other pathological gait videos associated too. I know I'm going through really fast, but it's more of just reviewing the videos, what they look like, being able to identify each one, and then, looking through the gait deviations, which, let's see, there's some different page numbers for that one too from score builders, but make sure you look over that gait deviations chart. Really need to be able to identify if there's foot slap, what does that mean? Weak dorsiflexors. If there's exaggerated knee flexion at contact, knowing the differences between each one of those. You can utilize PhysioU to role play with each one of those to see if you can identify them, what could you do to fix the situation. So pretty much what I just said about score builders and gait deviations, like I said, this page numbers are not exactly accurate. I thought I deleted those, I did not. But being aware of when to use an assistive device and adaptive equipment. So like I said, short and sweet and to the point, but I really want you to use your resources and identifying with the videos, each one of those, especially all the ones that are mentioned in score builders about abnormal gait patterns and how you would fix it. So just going through, maybe you can chart through each one or have a table. Like for instance, maybe it's the festinating gait or the ataxic gait, identifying what could be the differences with those gait deviations and how you can change that. So that concludes our session for today. Like I said, really short and sweet and to the point. And you guys have a great day. Thank you.